Good morning, everyone. Welcome to the session. I'm calling on stage Mr. Willy Ogier, along the panelists.
So speakers are invited to come up, please.
The panelists can go on stage, please.
Yeah. So good morning to everyone. I'm Willy Ogier, a health economist from Switzerland, working as a consultant quite 30 years. And I'm also president of SwissReha, the Association of Swiss Rehabilitation Clinics. I have the great honor and also pleasure to moderate this session about the transformation of healthcare and the evolving role of hospitals. We will analyze 3 different countries, their visions, and go a little bit in a deep dive of these 3 countries, all of them rich ones. Before doing that, Anne Bütikofer, General Director of the Swiss Hospital Association H+, will give us an introduction to the topic. Anne, please.
Ladies and gentlemen, dear colleagues, it's a pleasure and it's an honor to welcome you to the Swiss session of the World Hospital Congress here in Geneva, a symbolic place at the heart of Europe where visions, cultures and ideas from all around the world meet. Today we are going to talk about transformation, not about small adjustment, but about a true paradigm shift for our hospital system, and in particular for the Swiss system, which is currently going through a period of tension and profound questioning. Switzerland has long had a very high-quality health system. It is built on freedom of choice, competition between providers, and a strong regional anchoring of hospitals. It is a system that has proven its worth, efficient, innovative, and close to patients. But today, this model is reaching its limits. Swiss hospitals find themselves in a financial, strained, sometimes critical situation. Margins are shrinking, investments are being postponed, and regulatory pressure keeps increasing. We are living in Switzerland in a permanent contradiction, a system that is meant to be free and competitive, but which has now become over-regulated at every level by the federal government, by the cantons, and through a multiple of control, planning, and tariff mechanism. This regulatory density slows down innovation, makes daily management more complex, and weakens the economic balance of healthcare institutions. On top of that comes a major democratic shift, an aging population, growing needs in chronic care and long-term support, just as it becomes much harder to recruit and retain qualified staff. And our staff are committed, skilled, passionate, but often exhausted by administrative tasks, increased workloads, and the loss of meaning. Faced with this reality, the status quo is no longer an option. Transforming the traditional hospital system has become a vital necessity, not to abandon our values, but to preserve them over the long term. And to transform means daring to rethink our model, to review how we finance care, to fully integrate digital technologies and data, to redesign a care pathway around the patient, and to redefine the very role of the hospital within the networked health system. The hospital of tomorrow will no longer be only a place of care, but a key player in coordination, expertise, and innovation. This is precisely the purpose of the Swiss session, to understand how Switzerland, Singapore, and the United Arab Emirates are approaching this systemic transformation. Three very different countries, yet facing similar challenges: financial sustainability, democratic pressure, and the need to reconcile quality, accessibility, and efficiency. We will look at how these countries are adapting their governance, their funding models, and the role they assign to hospitals within an evolving health ecosystem. Transformation, ladies and gentlemen, is not a threat. Transformation is an opportunity to give new breath to our system, to unlock the energy and creativity of our teams, and to bring the core mission of hospitals back to the center, caring for people with humanity and excellence. I hope today's discussion will inspire concrete ideas, new alliances, and why not, a shared vision of the hospital system of the future. A system that is more agile, more interconnected, more intelligent, but above all, more sustainable and more human. Thank you for your attention, and welcome to this Swiss session of the World Congress 2025.
Thank you very much, Anne, for this introduction. We will start now with the three presentations about the three different countries: Singapore, the United Arab Emirates, and Switzerland. Then it is planned that we go in a deep dive on a closed discussion first on the panel, and then in a second half, we will open the discussion to you, that you have the possibility to make some questions and also your remarks, to finally come to a personal conclusion of each of the speakers at 11:55, if we manage with time. Let me first introduce Professor Eugène Fidelis-Saut, Deputy Group CEO of Population Health National Healthcare Group, one of the three great government-owned healthcare groups in Singapore. But as a health economist, I want also mention that Singapore is a country that is also at international level very recognized, because, as for example also Hong Kong, have an extremely low level of inequality in life expectancy, so they are even better than the Scandinavian countries, and they have also a long life expectancy in general. So at least from this perspective, it could be a benchmark country, and we could ask us, what can they better than we? And I hope, Eugène, that you can give us an answer. Please, welcome.
Well, very good morning, everyone. It's good to be back here in Geneva. And Singapore and Switzerland shares many things in common. And wonderful to be here in Geneva, where the crystal waters of the Rhone River joins up with the a bit more muddy waters of the Arve River. And today my story will be a narrative about how we are shifting our health systems towards population health and how we are building a system to accomplish that. I want to share with you a brief story of the Singapore River. It's a river that really sets the tone for transformation in Singapore. Founded as a port in 1819, it was later transformed into an entire river attraction. And then thereafter, when Singapore was looking at water resiliency, it became a reservoir. And today, we are building coastal palms on the southern edge of Singapore so that we can protect our low-lying Singapore landmass from the rising effects of carbon emissions. So the story of the Singapore River represents the type of transformation that we too like to see in our health system in response to the huge demographic shifts that we are seeing. Globally, you know there are two rivers meandering. One is that 10% of the world's population today will become 16% in 2025, right? That means that the aging is going to have a rapid effect on many health systems around the world. But similarly, the number of young people that we have is coming down. So that represents a huge challenge for many of us trying to deliver healthcare to our population. You know that one of the big goals of any health system is not only to live long, but live well. And the Singapore challenge is about closing the lifespan and the health span gap that we see. So Singaporeans are now living longest in the world according to the Global Burden of Disease Survey, but we spend about 10 of those years in poor health. So the big challenge for us is to try to close that gap. We also know that spending in healthcare is inequitable across the world. Singapore, we spend about 4.5% of our GDP on healthcare, fairly low compared to most developing countries, but we had a young population. So the key here is that moving forward, how do we bend the cost curve that we are seeing in our health system and to be able to address fundamentally the spend in healthcare across the sector. We know also within the sector there's a disproportionate use of healthcare and the cost of healthcare is much loaded to 20% of the population's needs. And that is where we also need to make it more equitable within our own system. We also know that before we hit the finance wall, we will likely hit the manpower wall because we are not having enough babies, right? So we're going to see globally a shortage of 18 million healthcare workers by the year 2030, and that is phenomenal. So I call this the triple threat of healthcare, right? We are living long, but in poor health. We are seeing healthcare expenditure being unsustainable, and we are seeing that manpower cannot pace demand. So how are we readdressing this through the redesign of our population health system? So I come from the National Healthcare Group, one of 3 integrated health systems. We started as corporatized organization in the 90s, then became fully integrated healthcare providers from primary care, hospital, community support, and today we have transformed that into regional health systems where I am accountable for the residents that live in the central and the north of Singapore, about 1.5 million of them. So that is what we serve, and we know we happen to serve the oldest parts of Singapore, and that puts us at a challenge for our own health system. What we are doing is that we are spreading out our services. So as much as we love our 3 big hospitals within the National Healthcare Group, what we are doing is embedding community health posts in every neighborhood across our entire geographical region, and that we co-locate with active aging centers to join up health and social care for our residents. And we're working more closely with our GP partners that are privately owned in a PPP sort of partnership. We know that the big aim in population health is to address the triple aim. How are we doing that? We need to be able to transform healthcare at many levels. First, to move away from episodes of care to relationship-based models, then wrap around that relationship-based models with more place-based type interventions, and then integrate care for those who require support for the larger health delivery system. And then ultimately, we are now moving into capitation, where we are accountable for the care, and we need to go upstream to understand the population health risks that we face. So I call this the population health stack, how we are stacking up all these different care models so that we can drive transformation at a system level. And when we do that, we hope to then give birth to the second river in Singapore, the river of life. The idea that we can join our residents in their journey from living well to living well. And no more are we talking about primary, secondary, or tertiary integrated care model. We're talking about redesigning our health system to a preventive health model at the front, an acute health model in the middle, as well as an aged care model to enable aging in place and place-based strategies. So that is what Healthier SG is. It's a preventive strategy out front. There's a national strategy. At the back end, there's an Age Well to be able to join up health and social care for our aged population.
Would you please come to an end?
Yes, so my last 2 slides, we need an engine, a deep learning engine to be able to transform care, joining up care models to technology, to workforce transformation models, and this must happen at all levels of care. And when we do that, we will be able to drive transformation at 3 levels, at the care level, where we address the iron triangle of healthcare, at the system level, where we look at the triple aim, and at the ecosystem level, where we are hoping to build health for generations to come. So thank you very much, and see you in Singapore.
Thank you very much, Eugene. Now I have the great pleasure to announce the president of the organization that organized this Congress. But not only Muna is a president of the International Hospital Federation, she's also chief medical officer at the Latifa Women and Children Hospital. Maybe for the, also from a health economic perspective, important is that the United Arab Emirates are considered as the best healthcare system in Middle East. So very welcome, Muna, please.
Thank you so much. I think it'd be hard to follow Eugene, after his presentation, but I'll try my best. So I think what I want to say is, we all have our challenges, some similar, but different countries, although we heard from the health economists that, we are considered rich countries, but I think many similarities across and priorities actually change for each country and what is transformation in that country. And I hope to take you through our journey of Dubai Health. So basically, Dubai, UAE is actually a very young country, 50 years, and in Dubai, we do have 3 authorities also in UAE. One is in Abu Dhabi, and Dubai is one, and then for the rest of the Emirates. And what I'm going to show maybe might be very specific to Dubai Health, but this is very reflective on what's happening in the rest of the country as well. So 2020, I think COVID hit. I'm glad that UAE really did an exemplary fight against COVID and really served people well. But that was an opportunity for us to think what's next. And having really the visionary leadership that we've been very lucky with, Sheikh Mohammed, who is not only ruling Dubai, but he's the prime minister of the whole country. And his vision, transformed actually UAE in the last 20, 30 years. He did say this quote that, health really becomes priority and is number 1 above everything else. So we had to think what's next for Dubai and what we want to do. And we all know that usually academic health systems are really best because we talk about financial sustainability, we talk about human resources sustainability. We want to deliver the quality care in the most and best efficient way. And when we look around the world, these are some examples. So Dubai thought that's what we want to do. And then looking into the governance, it was clear that integration and the governance was becoming more and more a trend and key in developing and delivering the best care. So for us, and this is basically, the missions of care, learning, discovery, and then supported really by a strong giving arm. So we made the value proposition of what Dubai Health want to do in the city of Dubai and to be an example. This is probably one of the important slides. So the regulator, Dubai Health Authority, on the far right of the slide, we separated actually. So we used to be the regulator and the provider. But as the city grew, and it was interesting to hear on sometimes, over-regulation really prevents you from innovating and having the agility. So basically what happened is as Dubai is growing and we have a huge private sector, the city decided that, you know, it's time to separate the regulation from the provider. So regulator today, DHA, does the strategy for the city, regulates and really regulates insurance and finances and the public health policy. And us in Dubai Health, we are the provider, the government side of provider, and are the academic health system. We collaborate very strongly with private sector because they do 60% of care and we do 40%. This is the components of Dubai Health. And then, transformation, what is our vision? Our vision is really together we advance humanity for health for humanity. And this is what brought us all together. And patient first is our primary value. Yes, we are academic health system, but it's important that the core business of what we do is health and taking care of patients, and academia, discovery, learning, giving, all actually supports this mission. Brand identity, just very quickly, this was our initial logo 50 years ago when the founder of Dubai had it, and we wanted to relate to it even with our new brand. So we went similar to the arches, and actually, interestingly, I was watching the video. We never knew who did this. And I just saw the video last night, the artist 50 years ago who developed this, and he was working in domes at that time. So this is our new logo that explains we're actually 3 arches, care being in the middle, learn, discovery, and really supported by a strong foundation of giving. The structure of Dubai Health, I'm gonna go very quick here because of time's sake. Our 5-year strategy really is to reimagine patient journey across. I think integration is key from before birth to the end of life. Establish programs that attracts and develops and retains professionals. We all heard this. We're losing people, and this is very important. Enhance discovery infrastructure.
Would you please come to an end?
Sure,
please?
last slide. And innovation, and really improve efficiency and capabilities across the system. Some numbers just to share how big we are in Dubai. And these were the guiding principles in the initial phase to make sure no disruption happens. And these were our timeline. We are in the transformation time. And again, just ending up with few numbers. And that brings me to the end. Thank you.
Thank you very much. So last but not least, I would present you Dr. Michael Thuram. He's CEO, General Manager of a very innovative Ensemble Hospitalier de la Côte, a hospital group that is much more than a hospital group. And he developed one of the first integrated, hospital-driven, integrated care systems in Switzerland. Please, Michael.
Thank you. Thank you, Willie. Thank you very much for the invitation, and thank you to Mina and Eugene. I learned a lot of your presentation, and I also see that we have some similarities and also some interesting differences with our situation in Switzerland. To start, in Switzerland, we have difficulties slowing down the rise of healthcare costs. Costs have been increasing for more than 20 years, and if we don't do anything, this will probably continue. Why? The Swiss healthcare system offers care for everyone, and I think that we can say that the quality of care is very high, but the system is built in a way that naturally pushes costs higher. This is how our health system works in Switzerland. We can explain it in a simple way. We have 4 main actors: patients, care providers, insurance companies, and people who are insured. People need care, they go to care providers, doctors, hospitals, home care, but each provider works with their own information system separated from the others. There is a national electronic patient record, but today it covers less than 5% of the population. So in reality, everyone still works with their own local records. And providers are paid based on the number of services that they perform. The more they do, the more money they receive. Insurance companies pay for these services and then increase insurance premiums. People pay these premiums, and premiums increase every year. Because patients do not see the real price at the moment of care, they use the system more like consumers. This creates a cycle. More care means more costs, and more cost means higher premiums. This is the core of the vicious circle in Switzerland. If I understand well, Singapore and Dubai also pay by service, but the system around seems to be a little bit different. In Switzerland, the vicious circle is not well regulated, we can say that, so costs continue to rise every year. This situation creates two risks. First, tensions. Each actor blames the other. Second, rationing, reducing access to care, which can lead to a two-tier system. In the hospital group I lead, EHC, we tried to move in a different direction. The first step was to organize ourselves as a network. 20 years ago, we were 3 hospitals. Today, we are an integrated group with hospitals, rehabilitation, long-term care, medical centers, emergency care clinics, and primary care center. We are present now in 40 sites, all connected with one shared information system. This is a real vertical integration. We think that we are better when we work as a network, but this does not change the vicious circle. We are still paid by volume. So we decided to change the financial incentive without changing the actors. With some insurance companies, we create a partnership to finance services that are not paid in the current system: coordination, prevention, and patient support. The idea is simple. If we invest in health of patients, if we help them live better with their conditions, they will need less medical care, and if costs go down, everyone benefits. We try to move from a vicious circle to a virtual circle, from a network of care to a network of health. This model was selected this year as one of the most innovative healthcare projects in Switzerland. But we must prove that this model works. It's the challenge now. To demonstrate this, we need scale. That is why we joined with the 4 other hospitals to cover a population of 1 million people. This network has been created in September. It is called the Blue Network. We believe that this network-based approach to health...
Would you also please come to the end?
Yes, sure. We believe that this network-based approach to health is one of the only paths we have today to control costs, improve population health, and avoid rationing. Thank you very much.
Thank you, Michael. So we come to the second part, short, closed discussion here on the panel. I will start once again with Eugène. you mentioned the young population. We could also mention that you has an international comparison less obesity, which of course means less healthcare costs. But I want to figure to another aspect. During my preparation for this session, I read that the government shared also to bundle payments to facilitate care transformation and increase efficiency. Could you explain a little bit what they do and why they do that?
Thank you. The big question first, right? So the question is about the sustainability of our health system going forward. Because one of the most difficult challenge that any health system in the world can address is that each generation pays for its own healthcare. And that if we pass on that bill to the next generation, we will have a very unsustainable model within healthcare. So the Singapore government has been building our financing models according to how we believe, as we pivot from a young population to an aging population, how can we align the incentives across the health system so that the health system will be incentivized to keeping our residents healthy and not just being a good production shop or a good repair shop. So one of that models has been the move to capitation, which takes a bit about half the spend in Singapore that is paid for by tax-based subsidies and use capitation as a mode of investment in health for our population. And that capitation is assigned to the 3 regional health systems in a payer-provider model that allows us to best direct the subsidies towards areas where we can help our population stay healthy.
And what means that for hospitals?
So that means hospitals also have to change their paradigms and their models. So as a health cluster, we are looking at where our budgets sit overall within the health system. And we want to be more intentional about shifting some of that resource to primary care and neighborhood health and working very closely with community partners. At the same time, we want the hospital to be more efficient, that there will be parts of our population that will require good specialist-based care. And that model has to be value-driven rather than volume-driven. So if you take the transformation, it's really at 2 levels: to optimize the BAU, manage the cost, manage the age standardized utilization for our inpatient admissions. At the same time, working on the health promotion of our residents so that we can keep them out of the hospitals.
Muna, you also spoke about integration, about integrated academic health system in your case. My question comes from the fact that in your country you have, let's say, from a perspective from outside, 2 systems. So you have the healthcare is provided for all nationals, while health insurance is said to be mandated for citizens of other countries. Which influence does this fact have to your model of integration? Do you offer 2 different pathways, 2 different kind of integrations, or how does it function?
Sure. So basically, our integration is beyond just simple service delivery. I mean, we are integrating many missions, which is, the learning, the discovery, but the care component is the biggest, of course, supported by giving, but also integration across the, patient care that starts from, from the prevention to primary, secondary, to all that. When it comes to the paying model, yes, you're right. So UAE nationals actually have both. They have insurance-based also, and in the public system, they have the coverage, universal coverage by default. So it's really, there is no different path when it comes to the care provided. It's just let's say the back office which deals with the payment and with the refunds. So everybody would get the care that they need. Now, whether they go to the private or to the public system, they would have coverage in both places. By default, UAE nationals always get the coverage in the public system, but they also have the provision of going to private because, I think we all know access becomes a big issue, and public systems usually struggle sometimes with that. And that's why the country wanted to give that accessibility to the very growing, fast-growing private sector to complement. And as far as other citizens, they also have through the universal coverage of, insurances that are very regulated also by the regulators, they have the access to the private system and also to the government system, but more so on the private. Now, how it works is, and I think this is the beauty of our system, we really complement each other. It's not a competition, but collaboration between the two systems. We consider the public sector being the safety net for the country and for the city. So where private doesn't want to really invest because it can be very costly, and when it comes to very complex care, critical care, that's where we are coming in the picture. And the straightforward, let's say, bread and butter, where usually you're still making also, you're having your finance sheet balanced, is probably for the private. So this has really helped. Now, it's not without its challenges because, again, it's a lot of cost, and that means we will always have people that cannot afford with their basic insurance the amount. But that's where government comes in, government support, plus the foundation that would support, financing this.
Michael, also a question for you. You described your system, but Switzerland is a country that has a tradition of managed care more than 30 years. This tradition was highly influenced by family doctors. Why took it so long that hospitals went to this way of transformation? When I compare that, for example, with another European country, in Spain, hospital-driven integrated care were introduced with the Alzira model more than 20 years ago. There are other systems also. Why took it so long in Switzerland?
Yes, part of the answer was presented before. It's important to understand that the Swiss healthcare was historically built on competition, on individual freedom, and institutional fragmentation. It's true that in Spain you have some integrated group. In Switzerland it's coming, but an integrated group needs things very different. You need cooperation, you need coordination, you need good communication, and you need population mindset. And we see now that there is a shift coming, but if you don't have these elements, it's very difficult to change and to transform the healthcare.
Maybe I can also mention that in a little country with 4 different languages and cultures, it's quite difficult to reach a critical caseload.
Maybe. I don't think it's the reason. Okay. I don't think it's the main reason. I think the main reason is how the Swiss system was built historically. And competition is one of the elements you find in Switzerland now, yes, today also.
So we are all children of history, but now it's your turn. I would say please wait till the micro will arrive, and then I propose you that you say who you are, which organization you represent, so that we know here a little bit from which perspective the question is rising up. So we have a first question in the front line.
I would like to thank all the panelists for this insightful contribution, and I would like to just tell my story, my mother's story. She had dementia. She is US citizen. I brought her in the last 10 years of her life to UAE. She was not taxpayer. She did not contribute to the economy of UAE. But for the last 10 years, hospitals were sending ambulance to my home 5 times a year with full coverage, 3 paramedics with doctor coming to my home free of charge, taking her to ICU. We did not pay a single dirham. My mother reached to the age 86, which is exactly the longevity of Singapore. 86 years of 10 years of dementia. And again, the healthcare system in UAE is amazing, extraordinary, doesn't distribute, doesn't differentiate between national taxpayer, not taxpayer, or expat. It's really amazing. I feel like UAE is pioneer in providing healthcare system with insurance, with high quality, with value-based healthcare, with a strong infrastructure. It's amazing. So I would like to thank Dr. Mona for really making I spend more time with my mother because of UAE. Thank you so much.
Thank you for this contribution. Other questions, remarks, experiences?
Hello, everyone. Good morning. My name is Zainab Youssef. I'm from Saudi Arabia, Eastern Province. I'm working in transformation and strategy as well. And our country been going through transformation, let's see, in the East since 2018. And we passed through a lot of changes and trying to pass the gateways of accountable care organization. We passed gate 2, still not announced officially, but alhamdulillah, we're there going. I have a question because all of you were talking about capitation and the integration between public and private sector. How does it affect the cost? How does it affect your budget? Especially like in Dubai, it's a lovely, amazing story of integration and collaboration between public and private. And you mentioned that it's 40% public, 60% private. But how does that affect your budgeting, especially with patient identification, beneficiaries, let's say, we passed, I think we don't say patients anymore, we say beneficiaries. So with beneficiaries identification, how do you identify patients correctly? How do you set your budget without it affect the care and outcome of your patients?
Mona, please, and then maybe Eugene also from a government-owned.
Sure. So actually, congratulations on on passing, and thank you for your question. I think it takes really a good governance and having the strategy for any transformation. I think in Dubai today, we were lucky that the regulator and the provider are, yes, they are separate entities, but really working very closely for that one purpose, which is, ensuring that customers, patients are getting what they need. And budgeting, I think, we all do that, and we all know that on year by year, the budget's always on the rise. Because, of course, also I think one of the challenges that we have, I see it as a challenge and an opportunity. In Dubai, our numbers, actually, population has been increasing rapidly. We went from 2.5 million to 4 million within a year and a half. And the expectation that this is going to go even higher. So, both, the regulator plays a big role here through the insurances and through the financing both sector, but also aligning that we both are in coordination. That has to happen. And again, it's not easy. There are challenges always, but I think stakeholders have to be all aligned to be able to deliver the best care, for the patient.
Vision, you mentioned yet the capitation. Maybe if you permit, I would add also the question. I know that in your system, especially telemedicine services and also hyper-productive polyclinics play a major role. So could you maybe also say something about that? Because there is, of course, a relation between the question and this transformation strategy.
Sure. So first to the larger question about the capitation model that we are building. Singapore has a hybrid financing model. So 50% is government spend and 50% is personal spend. So you need to understand the dynamics those two plays. The capitation allows us to focus on the population, allows us to create access, allows us to subsidize the cost of care for all our residents. On the personal spend part, we have two models there. A health savings account model that is tied to your pension plan that allows you to tap on a dedicated amount within your pension plan to pay for your medical expenses, and you can even share that with your family. So it has some risk pooling in the family level. The last part of it is really our pocket payments or employer sort of benefits. So we have a mixed model. The idea there is to balance the whole idea of access with efficiency and to be able to join up our entire health delivery model. So to the point of polyclinics and to the point, that is the part of the primary care that is provided by government. So 20% of primary care in Singapore are run by the 3 health systems that you have seen, and we provide those primary care directly accessible with very low co-pays to our community. But what we have done in recent years as well with Healthier SG is to extend portable subsidies out to our 80% of general practitioners out there through primary care networks so that will lower the barrier to accessing preventive health. And tying up those subsidies to preventive health programs that we would like to join up with the larger hospital system that we run. So this provides a collaborative approach. At the end of the day, there are 2 points that I want to make. There should be only one care plan for every resident. And if we can join up the care across the different fragmented models, then it allows the GP or the polyclinic doctor to help the patient navigate the system. The second point I want to make is that it does add some challenges to us as a health system because I have 2 denominators. I have the denominator that is our patients, and I have the denominator that is our residents that we are accountable for. I'm paid for by residents on a per capita way, but yet I serve residents as patients that come to my system. So we are still trying to align this entire system so that it gels. And ultimately, I think the goal is the same. How do we get the best health outcomes for everyone?
Michael, maybe also the question, what means capitation or bundled payment for hospitals? Which pressure comes up, and is this transformation strategy that you mentioned an answer to that, because you can control the whole pathway?
Capitation doesn't exist today in our system, and it is very difficult to build it. But Einstein said once to a journalist, that he want to die in Switzerland because Switzerland is always 10 years late. So maybe in 10 years it will be possible to have a full capitation. We tried, but it's today it's not in function in our system.
But there are other models in Switzerland where we have capitation.
Yes, but it's not a full capitation, and it's a capitation that integrates some parts of the pathway. Yes, it's true.
So I would invite you, first the lady over there in the fourth. Would you please so kind to leave once again your hand? So, no, she, okay.
Thank you very much for the panel. I'm Juliet Waterhouse. We are building an integrated healthcare system in Vietnam. And in Vietnam, there's virtually non-primary care. And we are trying to build a model so that the Ministry of Health can see what it is in practice so that we can apply it for the country. Ambitions, but we are working on it. And I've been doing it for the last 8 years. And I have a question for the panel. How do you incentivize the patient to go to primary care and GP clinics instead of going straight to the hospital? Because the problem that we've seen in Vietnam is the patient would rush into the top hospital with the tummy upset. So, and also the A&E care isn't, a night out and just break a finger and they go straight to the A&E. What a waste of time and resources. So I'd like to hear from the panel how you've done it in your country and how you do it successfully and effectively to move the patient from the specialist care to community primary care and vice versa, seamlessly and effectively. Thank you.
So if you permit, I would add also not only the perspective, how do you incentive the patient, but also how do you incentive the insured person, because an insured person is not necessarily a patient. Eugène.
Great question. I will start with a little bit of history. I think primary care systems around the world have been built on the gatekeeping model largely to access hospital-based care. And it was no different for Singapore, just rewinding the years, maybe 5, 10 years ago, was largely gatekeeping. And for you to be able to access subsidies in the hospital, you need a primary care referral to come in. But that in itself is not very satisfactory because it is another layer of care, it's added resources to be able to provide the gatekeeping and really not very efficient. So where we are going for with Singapore is we are moving to an enrollment model within primary care. So we start with preventive health, trying to get every resident to enroll with their GPs or the polyclinics. And through the enrollment, we built a relationship model. We built some portable subsidies that can flow into primary care such that they don't have to get into specialist care in order to access some of those subsidies. We can forward deploy investigations into primary care and give them better access out there. So that will then mean that those that are referred to the tertiary hospitals become more appropriate and therefore less gatekeeping at the point of care. I would say that there is a third model, which is a collaborative care model between primary care and specialist care. And I think that many countries in the world are working on such shared care models that enable us to have a pull system into tertiary care rather than a push system for primary care. And I think that redesign is in progress.
Mona, please.
Yeah, I agree, and I think we're actually moving towards that collaborative model where, your tertiary care actually is the one who's looking on who needs to be even sent and actually empowering the primary health care with the proper incentive supports to be able to take care, of patients there and only the one who need to go back. But I think, again, there are different ways of doing this. So now people want to get care closer.
to home. You know, people actually don't want to travel. I mean, I don't know about your cities, but Dubai, the traffic is bad, you know? And you really don't want to travel distances. So the more care you provide closer, actually people are happier. And one of the examples that we did also is, for example, we have our flagship children hospital, Al Jalila. We started in the neighborhood having Al Jalila. So we will have our primary healthcare center, but then they have Al Jalila logo up there saying, by the way, we are also here. And this has been helping patients, you know, because of course they want to rush with their kids to the specialty hospital because that's where they're going to get the best care. But when they do see that that specialist could also be there, who is taking care of them, this really helps, you know, decongest the congestion that happens at hospitals. So really thinking of innovative way of doing this. Telemedicine, I think today telehealth and home care, we're even going beyond just, you know, primary health care, reaching out to people in their places, because I think the trend is going to be out of hospitals, more towards home and communities.
Michael, in your system, how is the incentive?
In our system, the primary care doctor has a role, and his role is to be a gatekeeper. So the patient who is insured with our insurance model needs to go to the gatekeeper before, and the gatekeeper oriented the patient to the specialized or to the hospital. So there is a gatekeeper, and it's very important to have this, because you can organize and coordinate the care.
But if I understand the question correctly, then you should also mention that when you do that by your free choice, you have a premium reduction.
It's true. Huh? Yes, exactly. Yes.
So the last questions come from here, because we are quite finishing with time. So a short question, please.
Make it short. My name is Mo Castee. I'm the CEO of the Healthcare Leadership Institute. Work mostly with the U.S. Healthcare systems. One of the questions I always ask my CEOs of the various healthcare systems is, if I gave you a magic wand, what would you design differently in your system? Because it's hard with the existing system, always the constraint of to redesign it completely. If I gave you a magic wand, what would you do differently in your system?
Short answer, please. Hussein?
I was going to say everything. But basically what I hope to do is to flip the healthcare model. So today, the healthcare model is fairly reactive, right? And we're waiting for things to come our way, and we're kind of chugging along. So I always say the patient goes to the hospital because the hospital is where the resources is. How about the other way around? The resources follow the patient, and we are able to better organize care around the resident rather than around centers of care.
Una?
I would say, if I had that magic wand, I would want to see like data that, you know, analyze and driving us towards decision making. We are on that journey, but I think there's a lot of, you know, to be done, and I would like really for us to be that driven by data.
My key message is that in Switzerland, it's possible today to change things. It's possible to transform. And like I said before, I'm convinced that to build a health network is the only way we have today, and it's a way possible.
So as your question was quite the question that I wanted to put for the final, I give Gianni Rossi, Vice President of the Swiss Hospital Association, the possibility to put the very last question now, and then we will renounce to a great final conclusion.
Thank you very much. I think that we hear also that all healthcare systems are very under pressure in terms of funding. Personally, I think that one of the most problem is the lack of responsibility of the patient in using their services. I think in these countries where the government pay all. And I want to say, I would like to know what you mean about that.
Maybe, Eugene, this is a really interesting question concerning your region, because there exists, I don't know if you have read them, comparisons between national health system and your system and also Taiwan. And there is mentioned that one factor who explains these differences is culture. That you have a completely other culture in demanding health services. What would you say to this argument and to the question of Johnny?
Well, so I acknowledge the first fact that Singapore is a small country, small by population size, small by geography, and we tend to come together more often. And I think that is a strength of Singapore. And we tend to plan long-term in terms of the strategies that we want. And we have huge political stability, almost not moving sand at all between each election. So because of that, there is kind of a momentum of change that takes us along a certain trajectory. I think when we started the design of our health system and we designed our health savings account and as well as our delivery system, there was a key tenet that health must be for all, but health also is a personal responsibility. So in everything we do, there is a co-pay element within all our services across the board. There's means testing to help those who can't afford it, and there are safety nets to make sure that the lowest will be able to afford and access it. But short of that, it is a strong sense of personal responsibility for your health. The second evolution, which is now in preventive health and population system, there is also a collective responsibility as a community to be able to reach the unreached within our system. So what I see now is a tremendous push to get to about 15% of the population that is unreached by the health system. And that is where they end up in my emergency departments, and that is not why I want them to be. So this combination of both personal responsibility and the idea that collectively we can do good has been the tenets of the transformation ahead for us.
So, Muna, what would you say to this question? And if you permit also to add, you have 7 different emirates. So is there also a difference between the 7 emirates in culture, in patient attitudes? Because in Switzerland we have the differences.
So I think, going back to your question, I think it's a difficult equation usually when it comes to public, healthcare and provision. We do tend to see that over-utilization of health. But I think, our strategy has been, the more I think we go into preventative and promoting health is, I think, how we will come over on the long term, but it's not an easy, it hasn't been easy even for us. Going back to culture, yes, 7 emirates, and actually, even in UAE itself, the 4 million, we have over 100 different nationalities. So it is a very diverse culture, very different. For people from different emirates, it's not uncommon, for example, for the UAE nationals to go across. For example, we'll have people coming from anywhere, and similarly, people from Dubai. So having that access has made them, they might come to our system, go to their, Emirates system. And this is where I think we need to figure it out as a country level, but it's a mandate for all of us that, UAE nationals need to be treated. What we are doing also to help us, again, going back to that data, I think this is what is going to guide us on a country level. We are making the systems integrated today on not only on city level, but on country level, where systems talk to each other. So patients that are today going to a different emirate, to a different healthcare system, private or government, it shows, makes better judgment, and rather than just redoing everything, you look at it and you're able to see. So I think here is where collective data across the whole country is going to be able to help us a lot.
So, Mikhail, would you please so kind to also to answer, despite the fact that Johnny obviously know what you will answer, but for the participants of this session?
I want to end this session with, we can imagine new organization, we can change the system, we can evaluate, but behind every organization there is professionals, women and men working harder each day now, and when you applaud, please applaud for them. Thank you.
So we have yet past time. I would come to the end of this Swiss session, but not only without a great thank you to the three participants of the panel, a great thanks to Anne for the introduction, and maybe doing a last references to what we heard during this hour. We analyzed shortly and not in all the necessary details, 3 different rich countries from three different regions of the world. We saw, I guess, that there are some main topics that are common. Integrated care systems, not only hospital-focused or only family doctor-focused. The need for a remuneration across the whole pathway of the patient. We saw also that producing more in an outpatient field is a matter, and of course digitalization is behind all that, but not before that. But despite these common factors, I would also mention that we discovered a lot of difficulties for same instruments or same results, because point of departure in the 3 countries are very different. And if you permit that as a Swiss moderator to finish this session, it makes a clear difference if you have to contract a healthcare system on a Swiss Toblerone chocolate or on a Dutch Edamer cheese. Thank you very much.